Welcome to the Metabolic and Bariatric Surgery informational session. This session is completely free. Topics that we will cover today include metabolic and bariatric terms, obesity, what is it and what causes it, consequences of obesity, facts about metabolic and bariatric surgery, am I a candidate for surgery, timeline and process, metabolic and bariatric surgical options, surgical complications, and what are the next steps. Marshfield Medical Center in Marshfield has been named a Center of Excellence since February 2010 by the American Society for Metabolic and Bariatric Surgery. We are the only Center of Excellence in north central Wisconsin. Marshfield Medical Center is also recognized by Blue Cross and Blue Shield as an approved center of blue distinction for bariatric surgery. This is our metabolic and bariatric team. Our bariatric surgeon is Dr. Nirajogi. Our bariatric nurse practitioner is Amanda Connor, and our MBS clinical coordinator is Amy Kramis. Common terms that will be used throughout the informational session include metabolic, which is a Greek term pertaining to metabolism, and are chemical changes within cells to sustain life. Bariatric is also a Greek term relating to or specializing in the treatment of obesity. Body mass index, or BMI, is a calculated measurement using height and weight. As weight increases, your BMI also increases. Obesity is a medical diagnosis when BMI is greater than 30, and morbid obesity is a medical diagnosis when BMI reaches 40 or greater. Obesity is a common, serious, and costly chronic disease that continues to increase in the United States. According to the CDC, 1 in 3 adults struggle with obesity. The estimated annual medical cost of obesity in the United States was nearly $173 billion in 2019. The U.S. obesity prevalence was 41.9% in 2017. Obesity affects some groups more than others. In adults aged 20 to 39 years, 39.8% were affected by obesity. In adults aged 40 to 59 years, 44.3% were affected, and in adults 60 and older, 41.5% were affected by obesity. This is a diagram representing the prevalence of self-reported obesity among U.S. adults by state and territories in 2021. Several factors can play a role in gaining and retaining excess weight. These include diet, lack of exercise, environmental factors, and genetics. People gain weight when they eat more calories than they burn through activity, and this imbalance is the greatest contributor to weight gain. Studies have found that short sleep duration results in metabolic changes that may be linked to obesity. This is partly because hormones that are released during sleep help control appetite and the body's use of energy. Environment and social determinants of health. The conditions in which we live, learn, work, and play are called social determinants of health. It can be difficult to make healthy food choices and get enough physical activity if these conditions do not support our health. For example, not having parks, sidewalks, or affordable gyms make it hard for people to be physically active. Other community factors that influence obesity include the affordability of healthy food options, peer and social support, marketing and promotion, and policies that determine community design. Research indicates that genes can play a role in obesity. Changes in several genes may contribute to obesity by increasing hunger and food intake. Research also shows that genetic changes can directly cause obesity in certain disorders, such as Prader-Willi syndrome. Health conditions that affect our body's hormone levels, such as an underactive thyroid or PCOS, can cause obesity. Some medications, such as antidepressants, steroids, and birth control, for example, cause weight gain by disrupting the chemical signals that tell your brain that you are hungry. Long-term and short-term stress can affect the brain and trigger hormones such as cortisol that helps control our energy balance and hunger cues. The hormone changes can make you eat more and store more fat. Also, some people eat more than usual when they are bored, angry, upset, or stressed. This is a diagram representing the primary causes of obesity. Obesity in adults can increase the risk of certain health conditions, such as the ones that I have listed below. Being obese can have a serious impact on health. Over 230 comorbidities and complications of obesity have been identified. Carrying excess fat leads to serious health consequences such as cardiovascular disease, mainly heart disease and stroke, type 2 diabetes, musculoskeletal disorders like osteoarthritis, and some cancers such as endometrial, breast, and colon cancer. The conditions listed can cause premature death and substantial disability. The risk of developing a chronic disease such as gallstones, hypertension, and stroke increase with increasing BMI. Adults with obesity also have a higher risk of developing mental illness such as clinical depression and anxiety. This is a diagram indicating the medical consequences of obesity on the body. It is common for people seeking metabolic and bariatric surgery to have tried multiple diets and/or exercise plans. Many people lose weight while on one diet or another, but only a very small number of people can maintain the weight loss and regain the weight within a couple of years or less. Metabolic and bariatric surgery have proven to be the most effective and long-lasting treatment for morbid obesity and many obesity-related health conditions, such as type 2 diabetes. Other benefits of surgery include significant improvements or resolution in blood pressure, cholesterol, GERD, asthma, urinary incontinence, venous stasis, PCOS, sleep apnea, and decreased stress on joints. In addition to the significant health benefits, patients who have had bariatric surgery report having a better quality of life, improved self-image, and increased mobility and stamina. Bariatric surgery is a tool, and it requires a lifestyle change by you. We are your coaches to help you reach a healthier weight and maintain it. Our team is always here to support you through the process. Here is a diagram of how metabolic and bariatric surgery breaks the weight loss and regain cycle. Are you a candidate for bariatric surgery? Determine whether you meet the screening criteria determined by the National Institute of Health. Is your body mass index 40 or greater? Or is your BMI 35 or more and you are treated for one or more of the following obesity-related health conditions? Type 2 diabetes, obstructive sleep apnea, high cholesterol or high lipids, high blood pressure, coronary artery disease, heart failure, degenerative joint disease, reflux disease or GERD, asthma, or obesity hypoventilation syndrome. Additionally, have you made serious attempts at weight loss in the past? Are you able to understand the risks, potential complications, and benefits of metabolic and bariatric surgery? Are you motivated to make permanent changes in your diet, level of activity, and lifestyle to lose weight and improve your health and well-being? And do you agree to and are committed to adhere to the lifelong medical management and the recommendations of your healthcare providers? The Metabolic and Bariatric Program minimum requirements include attending the online informational session, completing the bariatric questionnaire, completing a consultation visit with the bariatric program nurse practitioner or surgeon, attendance at 2 support groups, 3 monthly dietitian visits in a row, bariatric psychology evaluation, and testing after 2 dietary visits are completed, and completing other visits as requested or needed. Other special reminders to keep in mind regarding program requirements is that your bariatric providers may request additional visits as needed based on your health conditions and ability to comply with the plan. Examples include additional nutritional visits, physical therapy, and sleep study. If you are not able to complete the program and drop out or delay for any reason, you may need to redo everything, depending on time passed and circumstances. If you have a mental health provider, they may provide the bariatric team with a letter or communications stating that your condition is stable. Our program requires a minimum of 3 months of dietary visits, but insurance frequently requires 6 months of dietary visits for supervised medical weight loss and bariatric surgery preparation. What if your insurance requires more than program minimum? You must complete any visits as needed beyond our minimum requirements as set forth by health providers or insurance. When done with all, the team will then review your case for approval and then send to insurance to ask for formal pre-approval of payment for your surgery. An additional special reminder regarding weight. Baseline weight is measured at the time of the first consult visit with the bariatric surgeon or nurse practitioner and is recorded in our documentation. Weight loss is expected during the preparation phase, and at the very least, weight needs to be maintained prior to surgery. Weight loss is required if BMI greater than 70 or is directly related to central obesity or health. Weight gain may result in either team denial, delayed, or canceled surgery. Here is the visual representation of the timeline for 6 dietary visits, which is our most common timeline. From months 1 to 2, you can expect to complete the informational session, have your consultation visit with the MP or surgeon, gather any outside records, verify insurance, and start to attend support group. From months 2 through 8, you can expect to complete your 6 dietary visits, your psychology evaluation, attend support group, and attend other visits to keep your healthcare up to date. From months 8 through 9, the team will review your progress and determine if ready for surgery, and we will seek insurance approval. At this time, you should finish any support groups that you still need. From months 9 through 12, we will schedule surgery, continue to attend any needed support groups, and then you will have surgery, and then complete post-surgery follow-up. Here's an example of a timeline for a patient who may need only 3 dietary visits. In months 1 through 2, you can expect to complete the informational session, complete your consultation visit with the MP or surgeon, gather any outside records, verify insurance, and start to attend support group. In months 2 through 5, you can expect to complete your dietary visits, your psychology evaluation, continue to attend support group, and attend any visits to keep your healthcare up to date. In months 5 through 6, the team will review your progress and determine if you are ready for surgery. At this point, we will seek insurance approval, and you should continue to attend support groups. In months 7 through 10, we will schedule your surgery, and you should continue to attend support group. You will have surgery, and then you will be expected to complete any follow-ups post-surgery. How can you be successful in our program? Attend all your appointments. At your initial consultation appointment, you will be given a patient binder. You will need to bring this binder to all your appointments. Manage other health conditions because you need to be as healthy as possible. Attend at least 2 support groups. Ensure your annual physical and dental care is up to date. Continue with daily activity. Lose and/or maintain weight during preparation. Ask for support and celebrate small victories every day. Patients are also expected to stop smoking or using any nicotine products 3 months before surgery, and we will confirm with labs as needed. If you have sleep apnea, you need to wear your CPAP every night. If you have trouble, go back to your provider as soon as possible to try different options, as we check download to verify. Unless documented by provider, you failed CPAP. If you have diabetes, your hemoglobin A1C must be less than 9. For females capable of childbearing, adequate birth control must be in place 12 to 18 months after surgery. For the next part of the informational session, I will discuss the surgery options that our program offers. Bariatric surgery works based on 3 mechanisms: restriction, malabsorption, and gut hormones. Restriction limits the amount of food that can be comfortably eaten at one time by reducing the capacity of the stomach. Malabsorption causes food and calories to be incompletely absorbed by bypassing a portion of the intestines, where this normally occurs. As for gut hormones, changes occur when removing part of the stomach or rerouting intestines, which promotes feelings of being satisfied or decreased hunger. Insulin sensitivity may also be increased. Other changes may occur, and research is ongoing. Some metabolic and bariatric procedures are purely restrictive. The stomach capacity is reduced, but no changes are made to the intestines. Purely malabsorptive procedures are no longer done due to complications. Combination procedures use both restriction and malabsorption. The stomach capacity is reduced, and a portion of the small intestine is bypassed. Our metabolic and bariatric surgeon is trained and experienced in doing laparoscopic surgery. Using this approach, the surgeon makes small incisions through which surgical instruments are passed. Most metabolic and bariatric surgeries are completed this way. Using the open approach, the surgeon makes one large incision. This approach may reduce the length of time it takes to do the procedure and may allow the surgeon to see the organs better. This is more common in patients that have had previous extensive upper abdominal procedures or if complications occur during the procedure. The first surgical option we offer is the vertical sleeve gastrectomy. The sleeve gastrectomy is newer and has gained popularity as it is technically easier to complete, and recovery time may be a little shorter. The sleeve is a purely restrictive procedure when done as a primary bariatric procedure, but also influences gut hormones that affect satiety, hunger, and how your body uses energy. While nutritional deficiencies may occur related to decreased acid in the stomach and changes in diet, they may not be as great as with the Roux-en-Y gastric bypass. However, lifelong supplements with vitamins and minerals, along with regular blood tests, are still required. The sleeve is created by removing about 66 to 85% of the stomach. This restricts food intake but allows slightly larger portions than a Roux-en-Y gastric bypass. It is critical that you control types and amounts of food or beverages you consume long term. This procedure is not reversible. Sleeve gastrectomy may not be an option for individuals with significant gastric reflux disease because it could make it worse. The second option we offer is the Roux-en-Y gastric bypass. The Roux-en-Y gastric bypass is considered the gold standard in bariatric surgery, meaning it is the procedure used to compare all other procedures and has been done for many years. The Roux-en-Y gastric bypass is a combination restriction and malabsorptive procedure. Restriction is achieved by creating a very small stomach pouch, which in turn limits the amount of food that can be eaten at one time. Malabsorption occurs when the new stomach pouch is attached to the jejunum, the second segment of the small intestine, after bypassing the rest of the stomach and duodenum, which is the first segment of the small intestine. Gut hormone changes, and possibly other things, help to increase satiety, decrease hunger, and improve how your body uses energy with decreased insulin resistance. Nutritional deficiencies may occur, and for these reasons, it is imperative to follow dietary recommendations, take vitamin and mineral supplements as instructed, and attend regular follow-up to see your provider for blood tests. This is a diagram that demonstrates the differences between the two procedures. You will notice that the speed of weight loss is faster with the Roux-en-Y gastric bypass, as well as the amount of weight that is lost tends to be higher in the Roux-en-Y gastric bypass. Both procedures will require lifelong vitamin supplementation, as they both do carry the risk of vitamin deficiency. The average hospital stay is the same for both procedures. Following surgery, you will follow up with the metabolic and bariatric providers at 7 to 10 days, 1 month, 3 months, 6 months, 1 year, and then annually lifelong. Metabolic and bariatric procedures done in the United States have significantly increased over time, while complications have decreased. The surgery requires a lot of education and personal commitment. Metabolic and bariatric surgery is only a tool, and like any other tool, it is effective if you learn to use it correctly. Surgery is one of the major causes of a blood clot. Some specific operations, including abdominal surgery, come with an increased risk for blood clots. This occurs because you are in bed for longer periods of time, and that slows the movement of blood in your body, which can lead to a clot. To avoid blood clots, it is important to be walking following your surgery. Smoking and nicotine use leads to decreased oxygen to organ tissues, which can lead to poor wound healing, wound infection, overall decrease of organ function, and ulcers are possible. Long-term smoking and nicotine is not allowed 3 months or more before surgery and never following surgery. Most leaks occur within the first week following surgery. Symptoms include abdominal pain, oral intolerance, and a feeling of doom. Patients may also have low-grade fevers, respiratory problems, and high heart rates. Some patients may develop a stricture or blockage at the opening of the stomach, even though they are following nutritional recommendations. Symptoms of a blockage include persistent nausea, vomiting, and abdominal pain. Transfer addiction is the act of trading one addiction for another. Some bariatric patients transfer their food addiction to something else, like gambling, sex, or alcohol. It is important to be aware of the risk and seek help immediately. Now that you have completed the online informational session, you will be prompted to complete our metabolic and bariatric questionnaire. This can be completed online, or you can request a paper copy to be mailed to you. Once you have completed the paper copy, please mail it back as soon as possible. Note, all online questionnaires will be sent right to the metabolic and bariatric department once completed. After we receive your questionnaire, you will be contacted to set up a consultation visit with our bariatric nurse practitioner. At your consultation visit, you can expect that we will discuss your health history, diet and exercise history, surgical history, family history, social history, as well as the different surgical options. You will also be given a patient handbook binder, which will serve as an informational guide for you through your journey towards and following metabolic and bariatric surgery. It is expected that you will bring this binder to all of your visits. If you have financial questions, they should be directed to our Patient Assistance Center at the number that is listed here. Any questions regarding metabolic and bariatric surgery or our program should be directed to our Metabolic and Bariatric Surgical Coordinator at the number listed here. Thank you, and we are honored to serve you and be a partner in your healthcare.